Hi, I'm Dr. Felice Gersh, your integrative OBGYN physician. We're going to cover a topic that comes up a lot. It's all about oral versus transdermal delivery of estradiol. I'll very briefly touch on oral conjugated estrogens. That is what was in the Women's Health Initiative, the brand name being Premarin. Now, the reason I'm going to touch on that first and then let it go is that it's quite well established that when you swallow conjugated equine estrogen, this is the estrogen product that is derived from the urine of a pregnant horse, that it contains horse hormones, estrogens that the horse now is actually trying to eliminate. And this is a pregnant horse, and these horse-type estrogens are not found ever in a human female. When you swallow them, they're converted in the liver. We call it the first pass through the liver. It goes in the mouth, into the digestive tract, and then into the liver. That's directly. It doesn't pass go. It doesn't get into the bloodstream until after that. So we call that first pass through the liver. And the conjugated equine estrogens, that means conjugation means it's gone through a process that went through the liver of the horse, which transformed it from a fat to a water-soluble product so it could be eliminated in the urine and then collected, as it turns out, and then turned into a product, a pharmaceutical given to human females. It turns out that when a human female then swallows this and it goes first pass into her liver, it increases the risk of blood clots, spontaneous, like deep vein thromboses, which could go and break off and go into the lungs, causing a potentially life-threatening pulmonary embolism, goes up 400%. So very few people, it's still on the market. There are people still being prescribed it, doctors prescribing it, but I'm not going to even go there beyond what I just said, because please do not take oral conjugated equine estrogens. The brand name that was and still out there is called Premarin. So I do not recommend that product. It's still on the market. It hasn't been taken off. It's totally legal. But let's talk about bioidentical estradiol. Estradiol, the type of estrogen made in a human female in her ovaries during the reproductive years. So if we take estradiol, the full name 17-beta estradiol, also known as E2, it has a big E and the number 2. If we talk about estradiol, we always say estradiol instead of typically saying 17-beta estradiol, but that's the same thing. If we take it orally, then is it any different than if you take it transdermally? Transdermal meaning through the skin. That's transdermal. Now, transdermal formulations can be as a patch, a gel, and there's a couple of different manufacturers of gels. It can also be given as a compounded cream, and there's even sprays that are deliver very small levels, but there are also sprays that go through the skin. So what's the difference and which is preferred, and why do I recommend transdermal, whatever form of transdermal is chosen? Because when you take oral anything, it goes through the digestive tract. Of course, you're swallowing it. Where else is it going to go? When you take oral estradiol as a pill, it will go also first pass through the liver, just like if you took oral conjugated equine estrogens. So it goes right to the liver. It doesn't go into the bloodstream. It goes into the liver through the first pass. Now, the liver is an amazing organ. It's transformational. That's what it does. It does metabolic transformations of one thing into another. The things that it's converted to, whatever it is that it's working on, are called metabolites. They're products of some form of transformational event that occurs in the liver. The liver has all these different ways to detoxify and change different combinations of chemicals, products that come from exogenous sources like outside the body or from within, endogenous sources. So these processes are called things like methylation, conjugation, sulfation, glucuronidation. These are all pathways in the liver to have this transformational process that occurs. So when you swallow oral estradiol, it is transformed in different ways. And it is primarily transformed into estrone. Now remember, estradiol has the symbol E and a number 2. Estradiol works on all the different estrogen receptors in a balanced way, the way nature intended it to be. But when you swallow estradiol, it goes into the bloodstream primarily as E1. That is a different form of estrogen called estrone. Now, estrone isn't evil. It's just that you're not supposed to have a big bolus of estrone coming into your bloodstream. Now, interestingly, estradiol and estrone can be converted back and forth from one to the other through a process involving an enzyme. Now, this enzyme is down-regulated, so it becomes less functional when you have a lot of inflammation. So inflammation sort of down-regulates, makes less functional this enzyme. So if you have estradiol converted into estrone in the liver, and then you have predominantly estrone going into the bloodstream, and you are a typical postmenopausal woman who is highly inflamed, unfortunately, that's what happens. You get systemic levels of low-level inflammation in menopause and aging. We call that inflammaging, the inflammation of aging, which I work really hard to prevent in my patients and myself. Okay, we do not want to be inflamed. But when you have inflammation, which unfortunately is very common, that enzyme is down-regulated, so you get stuck in estrone. So the dominant estrogen that is circulating in women in the menopause who are swallowing estradiol tablets is estrone, not estradiol. Then you may say, well, what difference does it make? Estrogen is estrogen. Oh, not true. Estrogen is not estrogen, just like trans fat is not like monounsaturated fats, which is like what olive oil is, or saturated fat, which is like what comes from like steak, the animal fat from a steak. So there are different fats, there are different estrogens. They work differently on the different estrogen receptors. So estrone, which should live in the female body, in balance with estradiol and be changed back and forth as the body needs it to be. Well, when you're stuck with too much estrone, and this is a little simplistic, but it helps to get the point across, and it's reasonably true, is that estrone is the dominant estrogen that is more pro-inflammatory. So what does pro-inflammatory mean? Well, the process of inflammation, which is critically important to save your life. If you're being invaded by a pathogen like a virus or a bacteria, if you're in an injury situation where, like a car accident, you're lacerated, something like that, you have injured tissue, because the process of inflammation is life-saving. You mobilize your immune cells. They go to the scene of the injury or the inflammation that's being generated by a pathogen like a bacteria or virus. And then the body's immune system works to take care of it, to isolate it, to wall it off, creating an abscess cavity if necessary, to dissolve and gobble up the pathogens, or dissolve and gobble up damaged or dead cells. So also, to create that wall for an abscess cavity requires platelets. And if you're hemorrhaging, like you're lacerated, you don't want to bleed to death. So you want your platelets to aggregate, to clump together and create blood clotting. That's really essential to survive when you're in a challenge situation and you need a pro-inflammatory process. But you do not want to have a pro-inflammatory process when you're just living your life, nothing's happening. But if you have too much estrone, you end up in a more pro-inflammatory state. As I just mentioned, a pro-inflammatory state will do a few different things. One, you're going to trigger constriction of your arteries because you have to maintain your blood pressure so you don't go into hypovolemic or septic shock where you have complete organ failure. We do not want that. So your arteries will constrict. Well, what if this is happening all the time? Well, then you will have hypertension. And there are published studies, in fact, a fairly recent one in 2023 showed a significantly higher incidence of hypertension, high blood pressure in women who swallowed oral estradiol pills compared to women who used transdermal estradiol. And in that case, they were looking at patches. So oral estradiol will increase significantly, and also, of course, compared to women who are on nothing even, will increase the risk of high blood pressure, hypertension. Well, what's also part of the pro-inflammatory status? Blood clots, because I told you, you don't want to bleed to death if you have a laceration from an accident. So what happens if you're always in a pro-inflammatory state? Because you're always swallowing every day estrogen in the form of oral estradiol. You're going to increase your risk of blood clots. Now, that isn't good. You don't want to have just spontaneous blood clots that can kill you if they break off if they form typically in the lower extremities, in the legs, deep vein thromboses, and travel to the lungs and can form a fatal pulmonary embolism. Fortunately, these are not common, but we don't want to increase the risk for no purpose. It's bad enough that we have to assume risk for all kinds of things in life. The last thing we want to do is have a higher risk than is actually necessary. So we don't want that. So those are two really good reasons why I would avoid oral estrogen pills, oral estradiol, oral conjugated equine estrogens. I wouldn't touch. But the oral estradiol, I would prefer not to use because of the increased risk of blood clots. And what is that increased risk? Well, some of the data suggests that it's about doubled the risk of the patches. That's why even in women who've had prior history of blood clots, it is not viewed as really an added risk if you use transdermal. Now, that is on the black box warning, so I'm not telling you that you should use any form of estrogen if you've had a blood clot. I'm just stating that the data has been quite investigated and is quite robust that transdermal estradiol doesn't increase the risk of blood clots, but oral does. And oral, now we have good data. This was a study that went in 2023, looked at the data of well over 100,000 women. So it's not really a tiny little study. Now it's looking at women. It's not a proactive, prospective study because they can't do that. I mean, you can't get hundreds of thousands of women or even 100,000 women and then give them the different forms of estrogen and then watch them for many years and see what happens. That study is never going to happen. So they're looking back at records, okay? But that they looked at the records of over 100,000 women for that study. Now, there's something else that's really important about when you take oral estrogen, estradiol. I already mentioned it goes right to the liver, first pass to the liver. So the liver is very affected by this estrogen that suddenly just shows up like a bolus, like, whoa, there it is. It wasn't there, now it is. All this estradiol showing up in the liver, first pass, all at once, not like trickling in. It's like, whew, there it is, all at once. So it actually has an effect on the liver itself. The liver makes all kinds of products. The liver is like a manufacturing center. So the liver makes things involved in blood clotting factors. And we now know that when the oral estrogen shows up, it actually increases the liver production of certain proteins and products that are involved in blood clotting. So it actually increases certain blood clotting factors. What else happens in the liver? Another product, another protein called sex hormone binding globulin increases a lot. Now, in some situations, people think that's good. Like, in what situation can that possibly be good, that you make more sex hormone binding globulin? Well, you need to know what it does, because otherwise, how would you have a clue? Sex hormone binding globulin, as the name suggests, binds sex hormones, predominantly testosterone. In fact, about 99% of testosterone is bound up in the blood predominantly to sex hormone binding globulin. What happens when you have less? Well, first let me touch on why some people would want to have more sex hormone binding globulin, and in what circumstance would that be considered a plus? Well, for women have too much testosterone and they want it to be bound up so it's not free or available, because if testosterone is bound up by this binding protein, then it can't act on the tissues like the skin, because too much testosterone, like in women with polycystic ovary syndrome who make too much testosterone, it can induce the creation of bad cystic acne, like in the chin line, the jawline, and also excessive hirsutism, that's like excessive hair, particularly on the face, and you get like a beard, and then a woman has to shave every day. That's not very pleasant. Or of course have laser hair reduction and hair thinning, androgenic alopecia, so she loses her hair over time, it all thins out. So in those cases, women would want to have less free or unbound testosterone, and they take birth control pills. And that is actually one of the benefits of birth control pills in that population. Now, I'm not going to go into it in great detail because there are other negatives too, but that is a positive. We always want to mention positives and not just, harp on the negatives, but that is a positive. So that's why there were certain birth control pills that actually went to the trouble, the manufacturers went to the trouble to get them tested and FDA approved for the treatment of acne. And the way that they work is that the estrogens that are in the birth control pills, predominantly ethanol, estradiol, they increase through the same thing, first pass through the liver, they increase sex hormone binding globulin, which binds up the testosterone, so you have less to work on the tissues. But what if you're a woman in menopause and you don't have PCOS and you're like, say, 55? Do you want to have less available testosterone? I don't think so, because as we age, our testosterone level tends to decline because of predominantly the area of the adrenal gland that makes testosterone. That's called the zona reticularis. There are actual studies, imaging studies, that show that as we age, that area of the adrenal gland tends to literally like shrivel up. So you make fewer androgens as you age, and testosterone is one of those androgens. 25% of all the testosterone circulating comes directly from the adrenal gland, and another 50% indirectly comes predominantly from the adrenal gland by conversion of androgenic precursors from the adrenal gland, like DHEAS, into testosterone. So as that area, and all of them come from the zona reticularis, as that area shrivels, then you get fewer of these androgens. So the amount circulating tends to go down, and androgens matter not just for sex drive, but also for sex drive, sexual response, but also for maintaining muscle mass and bone mass, so the strength of your bones and your muscles, and it affects the brain too. So it's really important. We don't want to lose our androgens. They count too. And of course, we can talk more about that another day, about how to replace them when you measure them and they're low. But when a woman takes oral estradiol, then what is going to happen? Her liver is going to make more sex hormone binding globulin, which will bind up the testosterone that she has, and less will be available to the tissues, essentially lowering her testosterone amount in her body, because what matters isn't the total, it's the amount available to the tissues. So that's a negative, because that can also accelerate bone loss when you don't have enough testosterone and affect other things as well, like sex drive. Now, also, the liver is the producer of 90% of the cholesterol that's circulating in the body and the carrier proteins for cholesterol. So you can see alterations in cholesterol. Now, I mention this not because it's good or bad, but because it's not really clear. So when you take oral estradiol, the studies show that you actually change how your liver makes cholesterol, and you can make, it's not a huge amount less, but it is less LDL cholesterol, low density lipoprotein. So cholesterol doesn't travel around the body by itself. It needs a carrier, like an envelope, like a letter has to be put in an envelope to be mailed. And cholesterol needs to be in a type of envelope in order to travel around the body. So incorporated with the envelope that comes out of the liver, that's called apolipoprotein B. That's a part of a larger structure called low density lipoproteins. So the numbers can go down some of this cholesterol carrying module, we'll say, when oral estrogen is taken. Now, does that translate into fewer cardiac events? We don't know. But recognize that what really matters is oxidation of cholesterol. Cholesterol can't just jump into arteries and kill you and cause plaque or anything of the sort. It has to become rancid or oxidized. And I actually shouldn't use the word rancid. I should say more like rusted, okay? So it becomes the equivalent of rusted cholesterol, and then it is problematic, it's damaged, and then it gets picked up by macrophages and it can end up in artery walls. But the bottom line is that there's no evidence that this mild decrease in LDL cholesterol that occurs with oral estrogens is anything more than just an influence on the liver and how it makes cholesterol. But what also is made by the liver, and this is a very important thing, is bile. And what goes along in with the bile is cholesterol. So we have gallbladders. I hope we're all born with a gallbladder. Some people don't keep their gallbladders, and that's sort of what I'm getting at. So the liver is what creates the bile, and with the bile is cholesterol. It goes out of the liver into the common bile duct. Okay, and then some of it will go also out into the intestinal tract, but some cholesterol mixed with bile, and bile is like a waste product of the liver, but it's also a signaling agent, it's an emulsifier, so it allows you to digest fats. It's a multitasking entity, and it ends up with cholesterol in the gallbladder. Now, it turns out when you take oral estrogen, estradiol, it increases the amount of cholesterol that gets into the gallbladder. It changes what goes into the gallbladder, and it also changes the bile. And it makes it into a more like thickened type of material. So guess what can happen? Gallstones. When you take oral estradiol as a pill, you increase your risk of developing gallstones in your gallbladder, which can lead to cholecystitis, that's inflammation of the gallbladder. If you get gallstones that come out of the gallbladder, they can get stuck in the common bile duct and create hepatitis, that's inflammation in the liver. They can go down and block the duct coming out of the pancreas and cause pancreatitis. They can get stuck in the little duct coming out of the gallbladder, causing inflammation, cholecystitis, inflammation of the gallbladder. You can get septic gallbladders and all kinds of pain and digestion problems. And it's a frequent cause, gallstones, of having to have your gallbladder surgically removed. And oral estrogen increases that risk. So that's another negative for taking oral estrogen. So when you look at it in totality, why would I want to take oral estrogen? It increases clotting factors made in the liver. It increases blood clotting through the production of estrone in the liver. It increases your risk of having gallstones. It increases your risk of high blood pressure. So it's not really my favorite. That said, if you're young, like say you're just at the cusp, just going into menopause, like you're say 47, 48, 50, the risk of all those things isn't high. In fact, women can, if they don't have any risk factors, can be on birth control pills, according to the official recommendations, up to age 55. So yes, I'm not saying it's horribly dangerous to take oral estradiol when you're younger. But why would you? I mean, why would you take something that is not as safe when you have a safer alternative? Also, you know I say this a lot, but I'll say it again. I am a simple thinker. Why would I want something that's having a pharmaceutical effect by going first pass into the liver, changing what the liver is producing, how the liver is working, creating potential alternative products? And why would I do that? And having a different form of estrogen circulating, even if I'm not too inflamed because I'm younger and I can convert a fair amount of the estrone that's made back into estradiol. Why would I want to do that? Why would I chance it when I can take estradiol through the skin? Now, whenever you've seen studies that show a better effect with estradiol taken orally compared with transdermally, how could that be? I mean, how could you have any studies that show a better outcome with estradiol taken orally? That is because it's not evil to have estrone. Estrone is not the balanced estrogen that estradiol is. It acts predominantly on the alpha receptor, but the alpha receptor does stuff, okay? The alpha receptor is good. It's just that you don't want an imbalance. You don't want to have almost all alpha. What about the G protein coupled receptor? What about the beta receptor? But what if you only have alpha? Is that going to not do any good? If you have an adequate amount, alpha is the dominant receptor on bone and muscle. It's also in the hypothalamus of the brain. It is also the dominant receptor for making nitric oxide, a critically important gas that's involved in function and health of the endothelium, the lining of arteries. So, of course, I'm not going to say there's no benefit in having the alpha receptor activated, but I want a balanced approach. That's where my simple thinking comes in. I want to try to replicate as much as I can, as close as I can, being reasonable and rational, the estrogen environment of a young, healthy 25-year-old. And that wouldn't be to have a body that's predominantly filled with estrone. But there are benefits to even just estrone, or mostly estrone. The other problem that sometimes can be in a study is the amount of estradiol that's delivered by the patch. Almost all the studies are with patches, is too small. When you actually look at the levels achieved, they're underdosing. They're giving such a little bit of estradiol. Of course, it's not going to do a great deal of good because they're dosing it too low. It would be like saying exercise isn't very beneficial. And then you say, well, how much exercise did you do? And you say, well, 5 minutes a month. It's like, I don't think that was enough to see any benefit. If you give the tiniest dose of estradiol in a patch, what the heck do you think you're going to find? You underdose the women, whereas you give a more viable dose when you give the oral pill. So we're not really comparing apples to apples when you look at dosing regimens. The bottom line is, it's your choice. Talk to your own provider, and then you decide what you want to take. I just want to present the facts and my opinion. My opinion is transdermal through the skin is superior to taking it orally, especially as you give a dose that's going to be up to the task you want to accomplish. We want to give doses that match the needs. We can't give a teeny dose, like you can't just exercise 5 minutes a month and expect to be incredibly healthy. It doesn't work that way. You're not going to build muscles. You're not going to get aerobic health if you exercise only 5 minutes a month. So let's think about giving more bioidentical hormones transdermally, giving biologically compatible doses to what a healthy woman would have naturally in her body, and skip the first pass through the liver and all its potential harms, especially as you age and become more naturally pro-inflammatory and naturally more pro-clotting and naturally more pro-becoming hypertensive. So think about it, make the best choice for you.